Thank you again for joining today's revenue leakage webinar. I'm Sherry Mobier, VP with Healthcare at RGP and the host for today. Today's program is being recorded. Please submit your questions or comments via the chat feature. 1 CPE credit is available for the live session. Eligibility requirements are: 1, please participate for the duration of this webcast. And 2, please make sure to answer at least 3 polling questions at the various intervals. CPE certificates will be emailed within 2 weeks of this session. And a reminder, please complete the survey that will be forwarded to you after this webcast. Thank you. We'll go ahead and introduce today's speakers. Tim Ng. Tim is one of our senior leaders at RGP Healthcare. He's been with the firm for more than 8 years and concentrates on leading large teams at provider and payer clients focused in finance transformation and revenue cycle and claims integrity, as well as operational improvement and risk mitigation. Mikhail Gorbatenko. Mikhail is the Vice President of the Healthcare Advisory Services at RGP. He helps his clients optimize their revenue cycle operations. Prior to joining RGP earlier this year, Mikhail spent more than 10 years working for a large revenue cycle outsourcing organization, where he led assessments, implementations, and transformation of all facets of revenue cycle operations across dozens of acute care and ambulatory clients. Through their hands-on and experience transforming revenue cycles for their clients, Tim and Mikhail developed the revenue leakage methodology that they'll be discussing on our call today. Thanks, Tim. Thanks, Mikhail. Mikhail, I'll turn this over to you.
Well, thank you, Sherry, for such a nice introduction, and welcome to our webinar. Today, we talk about revenue leakage. We start with defining how we understand revenue leakage, where it happens in the revenue cycle operations. We talk about how to diagnose if you do have issues with the revenue leakage, and then we'll share our best practices or our case studies with our clients who had similar issues and what we've done to fix that. With that, let's talk about our revenue cycle, how in RGP we interpret revenue cycle operations. First, we think in revenue cycle in 3 interdependent and very integrated categories. We talk about patient access, known as a front, encounter documentation, known as a middle, and financial services, sometimes referred as a back. So all those 3 categories are very interdependent. When we work with our clients, typically the 3 most common questions our clients ask us: where's my cash? Can I do it cheaper? And how can I make my AR smaller? So to address those 3 fundamental questions of revenue cycle, we develop our comprehensive methodology. And you can see revenue leakage addresses cash issue with what you can do to improve your revenue. And we talk about it today. On the left, in the middle section, we talk about cost reduction, and that will be a topic of our seminar in 2 weeks on September 29th. We'll talk about how automation, prevention, and workforce management can help you make your revenue cycle efficient. And we also develop an approach how to manage your account receivables beyond aging, but look at the development metrics, who's responsible for resolving those AR, and how to manage it, identify backlogs. And it will be discussed partially in our seminar next week on September 22nd. And with that, let's go to our first poll question.
Thanks, Mikhail. All right, the first polling question for CP credits. We appreciate you answering this question now. Thank you. When was the last time you performed a revenue leakage assessment? Within the last 12 months? Within the last 3 years? Or never? Again, when was the last time you performed a revenue leakage assessment? Within the last 12 months? Within the last 3 years? Or never? Please go ahead and answer. We'll give it about 10 more seconds and we'll look at the results. Okay, let's see the question results. Interesting. So 31 and 31% within the last 12 months and within the last 3 years, and 38% never. Interesting. Mikhail, do you have any comments on these results?
You know what? I was expecting number 2 or number 3 answer to be the most popular answer, and I'm impressed how that our participant have done some kind of revenue leakage assessment very recently. So very interesting. Thank you, Sherry. All right. Well, let's talk about revenue leakage and how we think of it. Our definition of revenue leakage is very much straightforward. Those are the areas of revenue cycle where providers are leaving money on the table. And we divided or organized revenue leakage categories in 2 major buckets. One is charge accuracy. It happens prior you submit the bill, and it's focused about documenting services and coding services accurately and everything you have provided to a patient accurately. Then second bucket, payment accuracy. That happens after you submit the bill, and it focuses on how well your operations are doing on collecting on what you have expected to get paid on. So if you think about charge accuracy, it first starts with a charge capture. There has been a lot of areas improvement been made in this area for the last few years with implementing software for electronic medical records or some other like a drug dispensing software to automate charge capture. However, we still see that is an area of opportunity for our clients, in particular when it comes to the capturing charges for secondary procedures, for implantable or complex pharmaceutical. And then when I mean complex, it's not necessarily complex by chemical substance, but complex on how billing units are converted based on the clinical units, which require sometimes manual calculation. So those are kind of areas where we see outliers where software or automation may not capture. And one way to address it is looking at your complex, almost frequent cases and doing a retrospective audits to see if you are capturing everything what you're supposed to capture. Then the next area of charge accuracy is clinical documentation. CDI programs are not new. They've been in existence for quite a while. Almost all hospitals or acute organizations have some kind of a CDI program where they work with their physicians to assure accuracy and completeness of documentation according to the services provided. But we still see it as the biggest opportunity where organizations can improve and improve their revenue and capture everything they owe. We also see CDI programs start to pop up in the outpatient settings, and that is another aspect of if you run an outpatient groups or ambulatory groups, potentially want to look at how accurately and completely you document your services. And finally, coding. This is the area where how accurately you code the documentations you have in the medical record. And similar to charge capture, there have been tremendous improvements in automating this area with a computer system coding software or software that do coding automatically, especially in the ED or outpatient area. But we do see, and the studies have published, if you do an audit, it's not uncommon to see close to 20% error rates for under or over coding based on the documentation provided. So it's another area. In addition to charge accuracy, once you send the claim, payment accuracy becomes very important. And as one of our colleagues, David, put it out, denials he considers the dirtiest word in revenue cycle. And denials is not new. I've been in healthcare for 20 years. And when I started just out of graduate school, denials were a problem. Here we are in 2021, and denials are still a problem, and they're not going away. And the way to combat it, it's through analytics and identifying the trends and working with the payers to fixing those issues. And David, our colleagues, is going to talk about it, how we use in RGP analytics in a approach to fixed denials in our next seminar next week on September 22nd. The other big area which became quite hot issue in the recent years, it's bad debt or patient collections and patient experience. It's no surprise that recently, if you look at your open AR, self-pay balances may have grown from a single-digit balances to 20+% of your open AR, and it's growing. Patient liabilities through deductible co-insurance are growing, and the way you approach it, how you collect from a patient's balances can significantly impact the bottom line. The other area for revenue leakage we find quite often is underpayments. And a lot of companies have invested into the contract management softwares, especially on the acute side. But even with those softwares, there are still issues. There's still opportunities to identify with underpayments, and more so, it's how your contracts are structured and how you versus payer interpret and load those contracts into your adjudication systems. And we go into more detail on the underpayments in the slides ahead. And finally, recoupments and refunds, credit management is critical. It's sometimes an afterthought in revenue cycle because you're giving away money. But if you don't have a good grasp of who's recouping money from you or how you're refunding money to the payers or the patients, it can be an area where you just giving money away and then turning it around and trying to collect from the same claims a few weeks down the road. So with that quick overview for revenue leakage, let's move it to the next survey question.
Thank you. Great. Here's the second polling question. Please go ahead and answer. What do you think revenue leakage is in your organization? Greater than 20% of collected cash, 10 to 20% of collected cash, less than 10% of collected cash, or no leakage whatsoever? Again, please answer poll question 2. Go ahead. What do you think revenue leakage is in your organization? Greater than 20%, 10 to 20, less than 10, or no leakage? Give it a couple more seconds. Okay, let's see the results. Aha, 10 to 20% of collected cash, 73%. Less than 10%, that's 27% of the population voted for that. That's a really interesting view. Tim, do you have any comments on these results?
Yeah, that's pretty spot on. That's where we basically find, in some organizations we'll find more, some will basically find right in that 10 to 20%. So that's pretty spot on. Of course, it depends on a number of different reasons. If you got unique services, or if you basically acquired new facilities, added new services, that obviously increases the number. But even if you're continuing on with operations like you always have, you'd be surprised how much revenue leakage still exists in your organization. So spot on.
Thank you.
So good morning to everybody on the webinar. This is going to be the part of the program we're going to talk about some case studies. So I started off as a Medicare auditor. I want to say that I actually chose that out of college and was bright enough to figure that out, but I really wasn't. I actually went into it because I got a free car from Medicare. But what's always been fascinating to me, and I spent most of my time divided between being either at a payer or at a provider or in consulting, is although I'm not a nurse and I'm not a doctor, I admire what they do, but I, in my work in revenue cycle or financial management, get to support them by making sure that what they do is documented appropriately and that we can code for it appropriately and we get the most reimbursement. So that's what we're going to cover, some case studies about some of the, not everything, but some common things that we still see out there that we hope you will look into your organization and see if that's the case for you and pick up some additional revenue. Now, we got to start this off by doing a disclaimer by saying that although we go over these case studies, they may or not apply to you for a variety of reasons. One, you may be, the services may not apply to you. Your particular payer mix may be different, so that that is an issue for you, or that your understanding from your MAC for your Medicare program might be different. So again, these particular case studies we're about to go over are ones where we're highlighting a particular issue that may or may not apply to you. And the key about that is you've got to look in your own data and see what the story is telling you from that data, whether or not these are applicable. But even if the specific situation doesn't apply to you, there may be something that's a parallel to it. So it's something definitely still to look into. So let's start with our first one. Our first case study is on denials. Everybody's favorite topic is denials. Not because we want denials and not because we like denials. We all hate denials, but however, it's the reality of life in a revenue cycle. So what is interesting about it is how often we still see the same type of denials over and over again. And the key that we all start with, or we typically start with, is we look at our 835 and look at our denials and say, okay, what do we need to split it between clinical versus technical? And then for those categories of denials that show up in 835, how do we work them? Well, what's really interesting, I think, is we've over the years looked at the 835 and tried to work through denials in our denial management functions, is the story isn't always what it seems to be. And so let's give you some examples of that. So a number of provider organizations found that the denial titled "Denials Due to Authorization Pre-Cert" made one think, okay, well, I must have missed an authorization, I must have missed a pre-cert, let me go back and beat up patient access. Why didn't you do this? But that's not always the case. In a number of cases, the payer just didn't update their authorization module. And so, so don't beat up your patient access folks first. Find out if your payer actually updated their file, because a lot of times, like us, they get busy. That may not be top of their priority. And sometimes it just goes through the system and ends up as an authorization or pre-cert denial, when in fact your folks actually did everything they were supposed to do, and it still ended up a denial. So don't beat them up first, check in that, and then if that's the case, they did update it, it's accurate, then you can go back. Another one that I find interesting too is prior payment adjustment denial. Now that one seems like, okay, that sounds like I put in this claim already and I must have gotten paid, and now I put it in again, some mistake or something wrong with my system, or there's something, my process is broken. But again, certain Medicaid plans, just out of creativity, I guess, have basically used this for informational purposes. So for non-payable items, so for those items in which you're billing for, which really, because it's a global bill, or because of another arrangement where, say, the ancillary charges are not going to be paid for, but the routine charges are, you still have to submit everything on that 837 anyway. So they're just going to deny the whole thing and then pay you back again on the routine charges. And it's just a quirk in their process. So again, the title of the denial doesn't always mean you should jump to, okay, I know what the problem is. Look more into it. This will give you another example. Service not covered. Okay, automatically when you see that, like, okay, all right, we billed for something that we shouldn't have billed because it's not covered. Well, no, not necessarily. Again, in this case, a couple of Medicaid plans were using this, again, for a non-payable item. But that doesn't mean that the entire claim is denied. It's not covered. Just, again, the previous example, perhaps it's routine charges that are, but not the ancillary charges, or perhaps there's a carve out that basically needs to be billed differently. So again, look at, when you categorize your 835 denials and you start working through them, or your denial management team start working through that, pay attention to what's really going on. Dig a little bit more into it before you start working them based on just the titles of the denials. So let's look at our last one. On this one, we've got a missing or invalid claim data. That comes up quite a lot. I see that over and over and over again. And here, in this example, the payer couldn't tell the provider what was missing or invalid. So in this case, what happened was, we went back, looked at what was billed, looked at the documentation, everything looked pretty relevant. In fact, previous claims that had been submitted that were very similar to these group of claims paid. So there was no reason that this should have been denied. So inquiring about that to this particular payer couldn't tell us, didn't know, just denied it. So what happened was that we said, okay, well, since you can't tell us what is the reason why you use this denial, why you denied it, we're going to resubmit it. And as a matter of fact, we don't want to resubmit. We're going to submit all of it all together, and we just need you to adjudicate it and pay us. And they did. And so for whatever reason, they had a quirk in their system, or somebody woke up that day and decided they didn't want to pay any claims. Who knows? But every once in a while, you get just these quirks, and you just got to, again, work them. Not always by the title, but again, look more into the details. So that's denial. So let's look at another one. Coding documentation. Also one of my favorite, modifier 59. Now, most of us who've been doing coding or documentation or billing for a while know what modifier 59 is. But you'd be surprised that where I see this most often now are actually in the physician billing. So in individual physician billing offices, a lot of changeover in staff, or the physician gets busy, or whatever the case may be. So for those of you who have large physician practices, especially independent physicians you've added on to your practice, this tends to pop up quite a bit. It's not the only place where this pops up. Obviously, it'll pop up in outpatient areas as well, but just in physicians, this is an opportunity for you to go back and look at your physicians if you're adding new ones on, and just educate them about this. So this is the case, as a reminder, and modifier 59 is used whenever someone, for instance, in this case, when we're talking about physician, they've come into your office, you've coded your E&M code, depending on whether it's a new visit or recurring. Let's say that this is a podiatrist. So podiatrist, you go to the podiatrist's office, you're going to do a follow-up on an issue that you previously had, and the doctor looks at you for like, oh, you got something else going on. Well, let me just take care of it here. So he takes care of it, or she takes care of it, and you walk out and you're happy, you're walking well, but he forgets about that and just bills the E&M code, or he doesn't communicate that to the individual who's billing it. So again, code your E&M code accurately, obviously, make sure you get the right E&M code, and code for the procedure, but remember that you need to add modifier 59 because it happened in the same time as the E&M visit. Say this was a follow-up visit and you performed a procedure that wasn't related to the recurring visit, and you need to add that modifier 59. There's a few points here to remember when you need to code for 59, modifier 59, which is if there's a different session or a different procedure or surgery, different site or organ system, separate incision or excision, separate lesion, separate injury, etc. Now, there are some really neat tools that are out there now that you can actually use to actually catch some of these. So you can catch them before they become a problem. So, definitely look into some of those tools. I've seen more and more automated tools to help coders, to help documenters, to help physicians, help revenue cycle professionals actually get ahead of this. So you're not looking at these things after they've happened, after you get a denial, but rather before, so that you can catch them before you release your bills out. Okay, so let's look at another one. CDI. I love CDI. Clinical documentation is super fascinating to me, mainly because of what's always missing in it. It tells a story. If you guys have worked with clinical documentation over the years, you know that to me, it's extremely fascinating. Everything from the hospital setting, from the history of physical to the operating reports to the nurses' reports and all the way on to discharge. Super fascinating stories. But what's always interesting and a challenge for coders and documenters is the frustration of, hey, I know what happened here. I know what the doctors did. I know what we did clinically for our patients. How come I'm not getting paid for that? Well, great question. And sometimes that call goes back into the documentation doesn't allow the coder to code what they perhaps see, or the technician to be able to code what they see. For a while there was a lot of focus by the government and insurers in particular, or the government in particular, but then also insurers as well, about overcoding or upcoding. And that was a small period. And really, we're not talking about overcoding or undercoding here. What we're talking about is accurate coding. And accurate coding is based on what is documented in the medical records. So let's go through some examples. When should you look at these medical records, and when should you query the doctor? Now I realize doctors are super busy, but when you're talking about, tens and thousands of dollars, it's worth it to be a friendly pest to your physician and try to get an understanding so that you can code accurately. So we'll go through some examples. If you interpret what a physician wrote in order to code accurately, or if you have to interpret what the physician wrote instead of it being very clear cut, then perhaps you need to query the physician. So if you look at it and go, okay, I think this is what he meant. I think you can't think about what it is. You got to know. You're, again, telling the story to the payer based on the code, based on the documentation. So if the story is not full, then it's time to query the doctor. Another one is if you see a diagnostic test that results in a condition that would warrant higher reimbursement, but the condition is not specifically documented by the physician, you need to query that physician. So for example, septicemia, a very common one. You see that the test came back positive, but the doctor didn't actually write septicemia anywhere in the documentation. Well, you need to ask, like, okay, I see that the test came back positive, but you didn't document it. Can you tell me, is this septicemia or not? So that I can code appropriately. Another one is if documentation for physician doesn't match up with the criteria for the E&M level code. So the physician is doing their visit, and then you see that they did a procedure and the two don't match up. You're like, okay, hey, you were seeing this physician, you were seeing this patient as a follow-up to surgery, but it looks like you also are saying that you did another procedure in here. Is that right? Well, maybe it's because that actually did happen, but the documentation isn't fully reflective of that and needs to be documented. Or maybe it is there and and therefore also needs modifier code 59. But again, documentation tells the story, and if it's not there, then the story is incomplete. Also, be careful of conflicting dosage orders. I still see quite a bit of this. So dosage that's ordered by a physician and then dosage that's administered. You'd be surprised how many times that still happens all through systems. And it's important to find out, there may be a reason why. Maybe the dosage that was ordered, the doctor meant to change the dosage because perhaps the patient was a pediatric patient and originally the dosage was for a non-pediatric, an adult patient, and they needed to adjust it appropriately for the pediatric patient, but forgot to go back and reflect the order that's a pediatric patient. That doesn't typically happen because obviously a pediatric physician takes care of pediatric patients and geriatric physicians take care of geriatric, et cetera. But every once in a while in a busy hospital, particularly in the middle of COVID, a lot of things go awry. And so documentation sometimes go by the wayside. So look at the dosage, and if you see what's administered and versus what was ordered is different, there may be a lot of different things going on. So check that out. Expensive drugs like an infusion therapy. If you see expensive drugs that are only partially used, in other words, if there is 50 milliliters and only 30 milliliters of that is used, then the question is, okay, what happened to the other 10 milliliters? In the case of certain drugs, you can't use them. You may not be able to use them on other patients, or whether it's prohibited or because it's not a variety of reasons. But if there's no documentation of the wasting of that as appropriate, then ask the doctor, what happened to this? Did it get used on another patient? And was it appropriate? Or did it get wasted? So that so that basically you can again capture the appropriate code for that other patient if it was indeed used for that other patient. So let's go to our last example. Observation, another one of my favorite topics. Observation has been debated ever since who knows when, perhaps when prospective payment came in, back and forth about, okay, when is a patient appropriately classified as an observation patient versus something else? So again, a lot of confusion around this, but let's put some clarity to this. Well, in the Medicare Claims Processing Manual, the CPM, it says don't report observations separately if any of the conditions that follow are in existence. If they're provided concurrently with a diagnostic or therapeutic service, if there's a routine preparation for recovery from a diagnostic test, or there's a post-operative monitoring during a standard recovery period. None of those are observation. Those are just, there's a waiting period because something has happened, whether that's surgery or because there was a test that's being done and you're waiting for the test results. All those are just, even if it's happening in a hospital, and in particular when it happens in a hospital, because that's when you see it. If you're in the ER and your patient's in the ER and you basically run some different tests and they're backed up, or they're basically, it's inconclusive, they got to run another test. All those things are not observation. They're part of the process for waiting for the results of the test in order to determine what your treatment is next, or your patient's treatment is next. Same thing on a postoperative. It's postoperative. Different patients respond differently to anesthesia. Some will basically wake up when they're supposed to. Some will take longer. Sometimes complications happen. But again, that period right after an operation, during the postoperative period, when you're in that area, that's not considered observation. So standing orders for observation following outpatient surgery are also generally, I should say, aren't generally recognized, and that's the case. So again, there is always a period, and it may be a long period, depending on the outpatient surgery. The physician may, be conservative and want to take a much longer time to ensure that there are no complications, there are no after effects from the anesthesia. So it may be, something that's really long in the outpatient area, and you may be enrolled in the inpatient area while you're waiting. But these aren't recognized as observation. This is, again, part of the operation, the outpatient surgery. So lastly, observation reported with revenue code 0762, and each hour that's reported after is with G0378 for Medicare patients. But again, confirm with your MAC, just that this is still the case. And then typically non-Medicare patients usually use 99218 through 99200, sorry, there's a zero missing there, 00 for reporting observation. But again, check with your payer. So those are some examples, some of our case studies that I hope they give you some insight into, okay, let me take a look at that again. Some of these, again, are common. Some of them maybe you haven't run into before, but it's an opportunity to look at your data, look at your cases and see, are there some things where I have missed reimbursement because either the documentation wasn't fully up to date or vetted, or because these are things that I wasn't aware of and I want to take a look at it again. All right. So I think we have another polling question.
That's great. Thanks, Tim. Poll question 3. Again, for CP, you need to answer 3 questions. So we appreciate you answering this question now. Question 3, where do you think the greatest opportunity is within your organization to improve revenue? In the CDI, coding accuracy, denials, underpayments, or self-pay collections? Question 3, where do you think the greatest opportunity is within your organization to improve revenue? CDI, coding accuracy, denials, underpayments, self-pay collections. We'll go ahead and take a look at the results. Coding accuracy, 27%. Nothing in the CDI. Denials, 53%. Maybe not surprising. Underpayments, 7%. And self-pay collections, 13%. Mikhail, do you have any comments on what you're seeing here?
Absolutely. I'm not surprised to see denials, even though healthcare industry combated denials for years. It's still a big problem. What I was interested to see, CDI did not get any votes because it's a typically area of opportunity for our clients when they take a look at them. And then the other area I looked at is self-pay collections. Is I would expect it a little bit higher based on what I've seen in our clients, but also, like Tim mentioned, is client dependent. So, but they're interesting results. Thank you, Sherry.
Thanks. We'll go ahead and do just a quick time check. We've got about 25 minutes left in this session, and we'll jump into payment accuracy.
All right. Well, let's talk about bad debt, or how I typically define it. It's uncollectible patient balances. If you look at the life cycle of patient collections, there are typically 4 distinct, I call it cycles, where you can attempt to collect from a patient. Pre-visit, time of service, early out, which defines time when a patient receives the first statements until accounts is placed to bad debt, and bad debt collections. Typically, what we see with our clients, bad debt collections almost always outsourced to a third party and manage, sometimes I would say poorly, just monthly reports received from a vendor. Early out, it's a mix, but quite often it is also outsourced to a collection agency. And if it kept in-house, it's typically not well built out. We don't have any very robust outbound capabilities or analytics. And time of services have been, I think for at least for the last 10, 15 years, we talked about how important it is to collect the time of service. And a lot of patient access team put a tremendous amount of effort at collecting the time of service. But there's still issues. For example, you have to have a right opportunity to estimate, software to estimate accurately collection the time of service, what to ask for. And some organizations are asking for prior balances as well, but there's also can be very technically complicated to determine what's the accurate prior balance, especially if you have a issue with credit balances on the patient side. Sometimes you are over collecting or refunding money and then money that you should have applied to other open balances. And a lot of organizations nowadays, especially in the ambulatory area, made an investment into standing up pre-visit financial clearance and collections organizations. And typically those are centralized organizations and advanced efforts been made to implement new technology like outbound dialer, text message, email notifications, build out apps to be able to estimate in advance, especially in the areas of high patient payments like outpatient surgery or radiology services, where deductibles and co-insurances can run in hundreds, if not thousands of dollars to let patient in advance what their responsibility should be, and potentially either collected in full or set up some kind of payment arrangement. So you are not trying to collect it in the back end. But what I want to talk to you today about, I call it the good old early out cycle. It's been in existence forever. And what happens, most of organizations have I would say 4-month cycle, 120-day cycle, where they send 3 statements once every month. And if money did not come in, they would send a last statement like pre-collection letter, and at day 120 or 150, they put in a collection area into the bad debt agency. Occasionally, some organizations would make phone calls, but what we find when we work with our clients, a huge opportunity. I'm talking about 20 to 30% in just that area of revenue cycle of self-pay collections. And let me give you an example. One of the metrics when I look at when I work with our clients is time to placement. How long does it take you to place an account or send a statement or place an account with the collection agency for early out from the time of services? And you have to break your accounts into 2 categories, uninsured balances and balance after insurance. And let me explain why. Balance after insurance, most of the organizations collect consequentially. It means they try to resolve insurance balance first, and then once that is adjudicated, accounts is flipped to a self-pay financial service, and then it's billed. If you have issues in your insurance world, revenue cycle world, you have backlogs with denials, especially low dollar denials, you're not working them. You are not posting cash. You have money sitting in an unapplied area for weeks before you find a right account to apply cash. Or you have a billing issue. For example, it takes you 2 weeks plus to document, code, and submit the bill and clear all the edits. That what ideally is a 30 to 40-day cycle to resolve insurance balance and place the remaining residual in the early out cycle, turns out to be 80 and 90-day cycle. And it's very, very common. In fact, I challenge you to look at your number. How long does it take you to place an account balance after insurance into the early out cycle? And if you think about it, if a patient is getting the first bill 3 months after the service, the likelihood of you chasing that patient down and collecting it is decreasing dramatically. For example, a number of studies been published that balances over 90 days, the collectability on those balances decreases by as high as 50%. So if you have issues sending accounts timely to the collection cycle on the patient side, it's something to look at. The other area to look at, I call it in the same good old early out cycle, I call it black holes. It is so interesting. And it's very hard to detect because not a lot of folks are paying attention to the self-pay. It's not a big, it wasn't a big issue. But what happens in self-pay, oftentimes accounts are placed on holds for one reason or another. Let me give you an example. If a patient calls in and applies for the application for charity, typically an account is put on hold for up to 30 days. And unless you have some kind of mechanism automatically release that account, or if you receive an applications to work that application, account may sit on hold forever. The other area is bad address. If your patient access team is not collecting accurate information, if you can see up to 10-15% of your statements come back with a bad address, undeliverable information, and unless you have a queue where or you have software or your vendors on top of it to work in those undeliverable statements by verifying address through United States Postal Services or LexisNexis, or if you keep it in-house, you have a queue where people have to clean up those accounts. They typically flag, we see very often with a bad address flag in the system, and a patient access team tasked to verify their addresses, and they never get done. It is rarely gets done. Another typical area where accounts get stuck is dispute. If I'm a patient, I call and I put say I did not receive the service, or I'm not understanding why I billed so many CPTs or charges. And if you don't have a good system to send that dispute to, especially if you use a vendor, because vendor will typically send a request to your case managers or your PFS team to look into that. And if your team is not on top of that, or your vendor is not on top of that, managing those responses, then accounts can sit there for weeks, if not months, before somebody replies to a patient. So what I'm trying to say, just an example, one client I worked with, they had close to 90 hold codes in their system. And it was going on for years until CFO started asking, why do I have so much patient balances over 365 days? And what we find out, they had a lot of accounts sitting in the hold status and not moving through the cycle. And by the time we finished the clean up and fix all the issues, we ended up adjusting quite a few balances because it was too late to send to collections at that point. So please be careful with the black hole, because you assume system move accounts automatically. But if you put different holds in place or flags in place that kick account out of the cycle, it will stay there. And the other area I want to talk to you about, the opportunity for you to save money in addition to collect money, is found insurance. I ask you, I challenge you, go and look, if you're using a vendor, bad debt or early out, look at their recovery statements, monthly statements you receive, and look where the cash is coming from. I wouldn't be surprised if 50% of their cash they collect for you comes from a found insurance. And if that is the case, you have a problem with assigning uninsured balances or balances where they have coordination of benefits issues to your vendors. And all what they do, just get a patient call on the phone, resolve that COB issue, or they run an easy scan for open balances for Medicare and Medicaid, see if patient qualifies, and then just submit the bill and collect their 5, 10, 15% fee, depends where they are in the early out and bad debt cycle. In fact, the best practice I recommend, you look for all the found insurance recoveries with your vendors on at least monthly basis, understand where it's coming from, what payers, what locations, and then work backwards to fix those issues so you are not just giving away your money or delaying your collections. So that is kind of and I know we getting close on time. The only one area I wanted to point it out, and we're still talking about early out. We have not even touched pre-service, time of service, or bad debt. But in early out, in the recent years, a lot of companies done a lot of great work on the analytics to identify not necessarily propensity to pay, but looking for affordability, how much patients can afford to pay, and tailor their recovery, or how you approach that collections specific based on their affordability. If you keep it in house, very often you don't have the capability to build robust system or analytics to identify what's the right cycle of work effort, and it may be worth investing it into other vendor or analytics software to build this kind of propensity models. Like I said, we see 20 to 30% increase in the early out recoveries just by looking at those three areas: time of service, black holes, and analytics associated with the propensity model. So Cheryl, let's hit underpayments. Let's talk about underpayments very quickly. That area, a lot of work has been done in this area. A lot of companies invested in. There's two ways to identify underpayments in my mind. One, you either invest in a contract management software that nets your gross balances at the time of billing based on your contractual terms, and then you compare a payment to your expected reimbursement. Or if you don't have capabilities or financial means to do that type of integration or implementation, you do retrospective audits to see. You basically manually review payments for your most common procedures or biggest pairs to see if you're getting paid against your contractuals. And what we see typically, they'll happen. There's three areas where you may get an underpayment. One, if you or your vendor loaded wrong fee schedule or contractual terms in their system. And the way to catch it, and the best practice, it's labor intensive, but before you even go live with the vendor or with the pair or with the new fee schedule, it's always beneficial, if you can, send a test file to see if they adjudicate the same way what you would expect them to adjudicate. If you cannot do that, you have to, within the first 90 days, do constant audits on the payments to make sure the system is loaded correctly, or fee schedule and contract term is loaded correctly on your side and on the vendor side. The other area is very common. We see where underpayments happen are complex contractual terms or gray areas. And what I mean by that, we are talking about maybe how you do carve-outs or stop loss calculations, or how length of stay adjusted your payment, or is there DRG outliers or high-cost drugs or implantable, those kind of exclusions. So if the terms are very complex, there's a very likelihood either your system or your pair system will not be able to handle it correctly. And in order to prevent it, you have to talk to your attorneys or executives who communicate contracts to negotiate contracts with your pairs. Give them feedback to make sure they're not agreed to something that is impossible to adjudicate for. And in fact, the best practice, if it's possible, before every contract is signed or amended or renewed, somebody from a revenue cycle team is able to review the fee schedule and payment terms and provide feedback if it's possible to adjudicate it using your contract management system or not. And a final area where underpayments happens, it's basically what you bill, your documentation does not support what you bill, and the payer will downgrade and pay at a lower acuity level. And it's what Tim mentioned, through CDI and coding reviews, and communicating back to your clinicians and the coding teams that is happening, so they can adjust their documentation practices is critical. The few things I wanted to point out, or I call the best practices to combat underpayments, would be: first, you have to have good metrics. You have to measure what is happening, and you have to set up some kind of goals, like adjudication accuracy by payer, or by procedures, or by locations, so you can compare who's doing better or worse. Next, get rid of all the gray areas as much as possible in your contracts. Make it black and white. And in fact, I would encourage you, every time you go live with a new pair, have a monthly or bi-weekly calls for the first 3 months where you discuss adjudication issues you see with the pair and they can fix, and you or pair are not sitting for months before it all can be adjudicated correctly. The other area I want to point out, I call it documentation accuracy. And in this case, I'm not referring to the clinician documentation accuracy. I'm talking about your denial specialist documentation accuracy. It's on you to be very clear if you're appealing for underpayment, to show how you calculate it and attach backup in the contract language to show that you follow contract language to calculate how you calculate the accurate payment, and let the payer dispute or your calculation. If you just send a general appeals, very likely you get nowhere. You have to be very specific in detail when you appeal those type of underpayments. I also encourage you to, if you have a bulk issues, to first resolve maybe 1 or 2 cases, and then use that precedent to bulk appeal the remaining cases. Things will go faster this way if you have an agreement how to solve issues, rather than bombard pairs with similar appeals over hundreds of thousands different cases. And finally, you have to have a champion who can communicate and work across your organizations, front and middle, and the contracting team. So somebody who cares, who really cares, since they're a full-time job to do that. All right, Sherry, what's next? Another question?
That's great. We've got 2 more questions left. We have about 8 minutes. Time check, and please put your questions in the chat and we'll try to address those at the end. Poll question 4. How important is increasing collections to your organization? Again, how important is increasing collections to your organization? Very important. It's a top priority. Somewhat important. We work on it when we have time. Or it's not important. Our revenue cycle is fully optimized. Go ahead and answer your question. Very important. Increasing your collections is a top priority. Somewhat important. We work on it when we have time. And again, not important. We're already fully optimized. Give it another minute. And again, please put your questions in the chat. We'll try to get to those at the end. If we run out of time today for some great reason, we'll go ahead and address those questions after the session today. Let's go ahead and take a look at the results. Yay! Very important, top priority. Almost everyone, 88%. That's great.
Yeah, that's exactly what I would expected. Obviously, collections are the financial lifeblood of providers, and you absolutely got to, look at that each time. And again, it just ties back to everything we've been talking about. If what you're getting in your lockbox, if what you're getting in, isn't ensuring that you're getting paid every dollar for what you did for your patients, you got to look at these things. We talked about a number of different things related to underpayments or bad debts, or some specifics related to CDI, some of those other things. And I was surprised, I have to say, that no one said CDI. Now, I will challenge the group out there. If you don't believe you have any CDI issues, let me come look and I will find some for you. Not because I'm looking for them, but just because I know they're out there. And that's all that is that you're just simply telling your payer, okay, keep the money. We serviced our patient. We did what we were supposed to do. We took good care of our patients. So just pay us what you want to pay us. So again, I was a little surprised by that answer. Not surprised by this one, but was a little surprised by that one. I would challenge you. And whether you have someone else look at it or you look at it, look at your CDI. And not to say that anybody's doing a bad job. That's not what I'm saying here. What I'm saying is that it's a complex function, all of it. Revenue cycle from beginning to end, and particularly in the middle, it's very complex. And there's just challenges, and with challenges always comes opportunities. And I guarantee you there are definitely opportunities in every single one of our clinical documentation and coding. Again, not saying it's anything bad for the people that they're doing a great job. It's just that there's just opportunities, just because things change. Payers, basically, you can't control payer behavior. We've got so many different components of this. We've got physicians, we've got patients, we've got our own documentation, we've got payers, we've got rack audits. We've got all kinds of things going on. It creates a complex system, and with complexity always comes opportunity. Thanks, Sherry.
Thanks, Tim. Mikhail,
Yes.
we'll go
Yes.
ahead and cover key takeaways. We've got just a few minutes left. Again, if anyone has questions, we'll go ahead and address those after the session if need be.
All right, I'll close it out. So few things. The revenue leakage is real, and I think most of us on the call realized it based on the answers I see. The good news, we can do something about it. They're all addressable. It just requires time and effort to do that. I am glad to see a lot of folks have done some kind of a revenue leakage assessments in the last 12 months. So, folks who haven't, I encourage you to do it. As an operator myself, I always liked unbiased opinion. It's a little bit uncomfortable when a consulting firm come in and kicks a tire in new operations. But what I found it, me as an operator, I don't have time or resources to do an assessment myself. It will take me forever. I oftentimes don't have analytical power or either brain power or system to crunch the numbers and data. So having a third party to kick the tires and see where the leakage is probably the fastest way to identify your areas. And most of the time I find the third parties will find the right areas for opportunities. They may be a little bit bullish or aggressive on the amount of opportunity, but they will find the holes in your revenue cycle. And I think what you have to remember, you can't fix everything at once. You have to be strategic. Less is more, and pick the either low-hanging fruits or something you can fix fast to get a credibility. Because some of the revenue leakage issues require a long time. I'm talking about months of implementations in a process we design. And finally, as with everything, there's a reason why you have a revenue leakage if you do have one. And it most likely will require an investment, either with people, analytics, new technology, or optimizing the tools you already have in place, or building the better controls to catch the issues sooner than later. So you would have to invest either with people, with money, or with your resources to fix it. So that is it, Sharon.
That's great. Thank you. Last question. Please answer for CP credit. What is the biggest challenge within your revenue cycle organization? Lack of skilled people, lack of technology and automation, or lack of well-defined processes? Go ahead and answer. We'll give you a couple of seconds here. What's the biggest challenge within your revenue cycle organization? Lack of talent, lack of technology and automation, lack of well-defined processes. Let's go ahead and look at the results. Interesting. Lack of well-defined processes was number one. Technology and automation kind of behind, which is interesting. Well, this is great information. Again, thanks for everything today. I did not see any other questions in the chat, but if you do have questions, feel free to go ahead and email those to us. Thanks, Tim. Thanks, Mikhail. We appreciate all of your participation today, and we appreciate you answering the CP questions. Please join us for the next webinar on Wednesday, next Wednesday, a week from today, 9/22, called Identifying Hidden Cash Through Data. If you have any other questions or would like more information, please reach out to partner@rgphealthcare.com. Again, partner@rgphealthcare.com. And again, we'll reach out and answer any other questions you may have. Thanks so much and have a great week, everyone. Take care.
Thank you.